Hello and good afternoon to those of you in the East Coast. Um, so we are continuing the Castor Pilot Project program aligning sessions. This is session number 3. I am going to be the facilitator this afternoon. My name is David Mendez. I am an associate professor in the Department of Health Management and Policy at the University of Michigan, and I am a co-lead of the um, Career Enhancement Core of the Center for the Assessment for Tobacco Regulations. And we our projects have been led by new and early stage investigator and with pilot projects that can inform FDA's tobacco regulatory actions. Castor has funded 21 pilot projects over 4 years, and the lightning talk sessions will feature 10 of these projects in asynchronous and synchronous format. And then you can access those presentations at the link provided to you. So we'll send out the link so you can have access to them. So we have already two sessions. This is session number 3, and we are going to devote this session to tobacco-related disparities. And we have two distinguished presenters that are going to, the first presentation is going to be by Dr. Luisa Kcomt from Wayne State University, and she's going to talk about trajectories of use, stress, and health among U.S. transgender youth and adults. And following her presentation, Dr. Pete Driezen from the University of Waterloo is going to talk about longitudinal trends in prevalence of menthol cigarettes use and disparities in use at subnational levels by sex, age, and race ethnicity. Findings from the International Tobacco Control U.S. Surveys from 2002 to 2020. I'm going to introduce the first speaker, Dr. Luisa Kcomt, who is an assistant professor at Wayne State University School of Social Work. She received her PhD from the University of Windsor in 2019. Following her doctoral studies, she was a postdoc research fellow at the University of Michigan Center for the Study of Drugs, Alcohol, and Smoking and Health. Dr. Kcomt has worked as a social worker in various clinical settings, including hospital, outpatient behavioral health, and hospice and palliative care. Her research agenda is motivated by over 20 years of clinical leadership experience and centers of substance use, health disparities, and healthcare access among sexual, gender, and racial ethnic minority population. Using a social justice lens, her goal is to advance health equity and promote the health of and well-being of vulnerable population. Dr. Kcomt is an Asian American woman and a first-generation college graduate. She has lived in 4 countries, Peru, Commonwealth of the Bahamas, Canada, and the United States, across 2 continents to date. Her lived experience and as an immigrant has fostered a social consciousness and empathy for marginalized and vulnerable populations. She is a licensed Master of Social Work in the state of Michigan. So with no more ado, I leave you with Dr. Kcomt, and I'm going to allow you to share your screen.
Thank you, Dr. Mendez, for the introduction and for this opportunity to share my research with you. Today, I'm going to highlight one of the initial studies from my pilot grant. I'm going to be discussing nicotine tobacco use among gender fluid and gender stable adolescents and adults in the US. I want to acknowledge my co-authors who collaborated with me on this study, Dr. Evans-Pulse, Mr. Engstrom, and Drs. Boyd, Velez, West, and McCabe. I'll begin by providing some context for this study. We've learned from prior research that nicotine tobacco use is more prevalent among transgender populations, that is, individuals whose gender identity differs from their assigned sex at birth, relative to cisgender populations or non-transgender people. We also know that the proportion of adolescents and adults who identify as transgender has been growing over time. So it's important to continue to study this population that's vulnerable to nicotine tobacco use. Although in recent years, there's been more literature about transgender health disparities, there's still limited information about gender fluid people or individuals who experience changes in their gender identity over time. Many of the existing studies on tobacco use among transgender people tend to conceptualize gender identity as a static construct using cross-sectional data. And so prior to this, no research has really explored the association between gender fluidity and nicotine tobacco use. So the aim of our study was to estimate the prevalence of nicotine tobacco use among US adolescents and adults who are fluid versus stable in their gender identities over time. Our data come from waves 2 to 4 of the population assessment of tobacco and health, collected from 2014 to 2018. We restricted our sample to US adolescents and adults aged 14 at wave 2, as they were eligible to receive questions about gender and sexual identity. We didn't use wave 1 data because the gender identity was conflated with the item assessing sexual identity. So the overall sample size for our study was 33,197 individuals aged 14 and above at wave 2. Our outcome variables are from wave 4, which consisted of past 30-day any tobacco, cigarette, e-cigarette, other tobacco, and poly-tobacco use. Gender fluidity stability was based on the respondents' self-reported transgender identity from waves 2 to 4 and consisted of 3 categories: cisgender stable, transgender stable, and gender fluid. We conducted multivariable logistic regression models to examine the associations of gender stability fluidity over 3 waves with nicotine tobacco use at wave 4. We adjusted for key covariates at wave 4, which included past year psychological distress, sexual identity fluidity stability, which was determined by the respondents' endorsement of their sexual identity over waves 2 through 4, and socio-demographic characteristics, which included sex, age, race, ethnicity, and US Census region. We found that an estimated 1% of adolescents and adults were classified as gender fluid, and about 0.1% were transgender stable. Results from our bivariate analyses showed that transgender stable and gender fluid respondents reported significantly higher prevalence of any nicotine tobacco use compared to cisgender stable individuals. Results from our multivariable models, which is depicted here in this figure, showed that gender fluid respondents, noted in dark blue, had significantly increased odds for past 30-day any tobacco use, cigarette smoking, e-cigarette use, other tobacco use, and poly-tobacco use compared with cisgender stable individuals. In our multivariate models, transgender stable individuals were not at significantly higher risk for any of the past 30-day tobacco use outcomes relative to the cisgender stable individuals. We also found that gender fluidity was more prevalent among adolescents and adults, young adults, relative to the other adult categories. So we conducted interaction tests to examine whether the relationship between nicotine tobacco use and gender fluidity stability was moderated by age. We found no significant interactions between age and gender stability fluidity, suggesting that gender stability fluidity has a similar association with nicotine tobacco use regardless of age. So in summary, our study is the first to estimate the proportion of individuals in the US who are gender fluid using a longitudinal nationally representative sample. In a nutshell, our study showed that gender fluid individuals are at higher risk for nicotine tobacco use, which places them at greater risk for smoking-related health consequences. It's really important then for healthcare providers and tobacco cessation specialists to develop an awareness of gender diversity and to understand that gender identity can change over time. And so efforts should be made to create a welcoming and inclusive environment for individuals who may not subscribe to a fixed binary conceptualization of gender. My future research will include examining the influence of social ecological factors, such as state-level policies related to sexual and gender minority populations on nicotine tobacco use. So thinking about those macro-level variables. The PASS study recruited a replenishment sample at wave 4, so we can use additional waves of PATH data to potentially increase our sample size of gender fluid participants. Future research can also examine sexual identity fluidity and its association with tobacco use. In fact, our team currently has a manuscript under review on this topic. You can access the full paper, which has been published in the Nicotine and Tobacco Research Journal using this QR code. We greatly appreciate the financial support received from this pilot grant, as well as the other funding sources listed here. I want to also take a moment to acknowledge the impact that this pilot grant has had on my career. I'm incredibly grateful to be chosen as a pilot grantee, as I know that this opportunity has contributed to my success. Being a part of this network has provided me with access to numerous educational resources, such as the workshop by Dr. Ella August on data visualization and resources teaching us how to create more effective presentations. Creating this e-poster that's scrollable on one's phone is one example of how I'm trying to practice or experiment using these skills. This grant has also helped me to produce multiple first authored and co-authored poster and oral presentations at scientific conferences, such as the Society for Research on Nicotine and Tobacco, as well as the College on Problems of Drug Dependence. In fact, I'll be presenting at the upcoming SRNT annual meeting in March. I currently have one published first authored manuscript and a couple others in development. I also have multiple co-authored manuscripts currently under review. This pilot grant has provided me with preliminary data for 2 NIH R21 grant applications. Although, unfortunately, these grants were not funded, they did offer incredible learning experiences. The great news is that within the past month, my team and I recently received news that our R01 applications were awarded funding, and I'm serving as a co-investigator on those projects, one of which is actually on e-cigarette use among youth and young adults. I also very recently received news that I was awarded funding as a co-PI on a foundation grant. Now, although the foundation grant is not focused on nicotine tobacco use per se, having served as a PI on this pilot grant is now a part of my track record, which certainly supports me to be successful with future applications. So this pilot grant is helping me to meet the metrics to eventually achieve tenure at Wayne State University. And for that, I'm very, very grateful. So thank you again for this incredible opportunity.
Thank you very much, Dr. Kcomt, for this excellent presentation, and congratulations on all the success that you had following your research. So we will have questions for Dr. Kcomt after all the presentations are over. Now we are going to welcome Dr. Pete Driezen, and wait 1 second here. Dr. Driezen is a research assistant professor with the International Tobacco Control ITC Policy Evaluation Project in the Department of Psychology, and holds a cross appointment in the School of Public Health and Health System at the University of Waterloo. He's also a co-investigator with the International Cannabis Policy Study. His background is in epidemiology and biostatistics, and he earned his PhD in public health and health systems from the University of Waterloo in 2017. Pete specializes in the statistical analysis of complex survey data, regression modeling, and longitudinal data analysis with an emphasis on generalized estimating equation, GEE. He is also interested in spatial data analysis, a small area estimation using survey data, and employment of data science methods and tools to support evidence-informed health policy. Pete's primary research interests lie in understanding geographic factors influencing population health and how health policy influences human health and behavior at small area levels. In addition to his work with the ITC project, Pete has been involved with research on web-based assessment of adolescent nutrient intakes. With no more ado, I leave you with Dr. Pete Driezen.
Yes, thank you for that introduction. So I'll just be presenting findings from my pilot project supported by Castor, examining subnational trends in the prevalence of menthol cigarette use and disparities in use over time in the United States from 2002 to 2020, using data from the ITC US surveys. So just by way of background, we know that targeted marketing of menthol cigarettes in the United States influences disparities in the prevalence of menthol smoking across different demographic groups. And data from recent data from the tobacco use supplement of the current population survey show that the prevalence of menthol cigarette smoking among current smokers increased from 2003 to 2019, and that menthol cigarette use is more common among specific demographic subgroups, including young adults, females, and non-Hispanic Black smokers. But what we don't really have at this point is more granular information about menthol use at subnational levels. And I believe that these data can provide greater insight into the possible effects of the proposed FDA ban on menthol cigarettes. So the overall objective of this particular study was to estimate trends in the prevalence of menthol use among current adult smokers for each of the 9 U.S. Census divisions by sex, age group, and race and ethnicity from 2002 to 2020. And this map just shows the different census, the 9 different census divisions in the U.S. and the states contained in each of those divisions. So the general approach that I used was a small area estimation modeling approach. And the purpose behind small area estimation is to estimate reliable statistics using population survey data for specific subgroups where the sample sizes in those subgroups are very small. So population surveys typically aren't designed for estimation with these small subgroups or domains. And SAE methods usually estimate these statistics using linear mixed effects models. And this study I'm presenting here relied on a specific type of SAE model called multi-level regression and post-stratification. So in terms of data, the primary data for the study, for the modeling part, come from the ITC US survey, which just by way of brief introduction, is a national representative sample of current adult smokers in the United States. It uses stratified sampling design. There are 12 waves conducted from 2002 to 2020, split across the initial ITC4 country survey and then the follow-up study that began in 2016. So this study uses over 22,000 observations from 12,000 respondents, and the primary outcome measure was use of menthol cigarettes, which was either self-reported use of menthol cigarettes or self-reported cigarette brand, which contained the term menthol. And to conduct the estimation of menthol prevalence, I had to also rely on external data sources, those being the U.S. Behavioral Risk Factor Surveillance System and the American Community Surveys. And these surveys were used to estimate the total number of smokers within each census division for all survey years. So these data are really used in the second step of the modeling approach to estimate menthol prevalence. And then I also used data from TUS CPS, waves 6 through 10, to validate the modeled estimates from ITC. So multi-level regression and post-stratification, as its name suggests, it fits first a multi-level regression model to predict the outcome measure in specific subgroups. So what I did here was I predicted the prevalence of menthol use among current smokers for 72 cross-classified demographic groups of smokers. So what that means is I wanted to predict prevalence in 18-year-old males who are non-Hispanic, white, and of low socioeconomic status. And if you cross-classify those four variables, you get 72 different demographic groups. The idea is to predict prevalence in those groups. And then in the post-stratification stage, we're weighting those estimates to get sort of an aggregate average at the census division level. So in the regression model, demographic measures were fit as fixed effects. I also accounted for time trends using piecewise linear trends. Census divisions were fit as a random intercept, and I fit a bunch of different models, but the final model also included a random slope for race and ethnicity. And again, the predicted prevalence in the post-stratification stage is weighted by population totals for each of the cross-classified demographic groups, and then it's aggregated to census division level in each survey year to obtain estimates of overall menthol prevalence and then menthol prevalence for specific demographic groups. And 95% confidence intervals were estimated using a non-parametric bootstrapping procedure. And again, modeled estimates were validated against external direct estimates from TUS CPS. So just in terms of the overall results, the ITC modeled estimates are presented in blue and the confidence intervals are shaded gray, and then the estimates from TUS CPS are presented in red. So generally what we're seeing is that there's pretty good agreement between the modeled estimates and external estimates from TUS CPS. And generally, in all census divisions, there was an overall increase in the prevalence of menthol use among current cigarette smokers over time. But there's also variation between census divisions in the magnitude or the level of prevalence. So the Pacific region tended to have the lowest estimated prevalence, and the South Atlantic and Middle Atlantic divisions tended to have the highest overall prevalence of menthol use. Presenting the data cartographically, this plot shows estimates for males and females in 2002 and 2020, and we're seeing the same general patterns of results. There's a general increase over time among both men and women, and the highest prevalence tended to be in the Middle Atlantic and South Atlantic regions for both males and females, and the lowest prevalence tended to be in the Mountain Division in the West. In terms of differences or trends by ethnic groups, the overall trends for non-Hispanic white smokers were generally quite similar to those of the overall trends, but there were significant differences when we looked at other ethnic categories. So among Black smokers, we can see here that the prevalence is a lot higher, and there was also not really a noticeable increase. The increases in prevalence were quite small over time. And there are also greater differences between estimates from TUS CPS versus the ITC modeled estimates. So for example, in New England there, the ITC modeled estimates are off by quite a bit, but in the Mountain Division, the estimates are a bit more similar, but there's also wider confidence intervals. And it's also important to note that even in TUS CPS data, the confidence intervals are quite wide for the estimates. Turning to Hispanic smokers, we're seeing also higher prevalence of use. Again, wider confidence intervals for both sets of methods. More agreement in some areas than others. So Middle Atlantic, the estimates were off by quite a bit, but in sort of the East, North, Central, and Pacific regions, the estimates were closer together. And similar ideas for other ethnic groups, all other groups combined. In terms of model validity, the overall estimates were quite reliable. So the left-hand scatter plot is a plot of the modeled estimates against the direct estimates. The black line is the overall concordance line or line of perfect agreement, and the red line is the line of best fit when you regress the modeled estimate on the direct estimate. So overall, there is quite good agreement between modeled estimates and direct estimates. That was true also for males and females, estimates stratified by males and females, and for white smokers. But again, the agreement was lower for non-Hispanic Black smokers, was a bit higher for Hispanic smokers, and for the other groups, agreement was not so good. So this plot here then focuses on the disparities between groups for males and females across all census divisions for each of 2 survey years. So there's a lot of data presented here, but I want to just kind of focus on the key points. So there's for each census division, there's 2 plotted time points, 2002 and 2020. And the difference between each group is the absolute difference in prevalence, and then the size of the dot represents sort of the relative difference between groups. So generally what we see is there's no real change in disparities in use between each of the ethnic groups compared to white smokers. So over time, we're kind of seeing that, disparities remained relatively constant. There were greater disparities for some ethnic groups in some census divisions than in others. So in the Middle Atlantic region, Hispanic smokers much more commonly used menthol cigarettes than white smokers, but in the Pacific division, estimated prevalence was quite similar. And then also among females, again, there's really no difference in those census divisions. And that just kind of summarizes what I just said. And then in terms of implications, the proposed FDA menthol ban may exert different effects across geographic and demographic subgroups. And the overall effects of the ban will depend on the demographic composition of the population of smokers in each of the different areas of the United States. Smoking cessation interventions in different states should tailor services to smoker-specific needs to encourage menthol smokers to quit following implementation of the FDA ban. And some areas of the U.S. will face larger challenges supporting menthol smokers in their efforts to quit than others, given the size of the population and the prevalence of use in those areas. So, for example, states in the Middle Atlantic and South Atlantic where menthol use is much more common. In terms of future directions, I've kind of thought about adapting the small area estimation methods for tobacco control policy evaluation at sub-national levels using survey data, and then applying these methods to other domains such as problematic cannabis use at subnational levels in Canada. And I'd just like to thank the Castor program for supplying funding to conduct the analysis for this work. And I'm currently working on writing up the first paper for this project, which is this one presented here. And then I just want to note that funding for the ITC study came from USNAH, Robert Wood Johnson Foundation, and the Canadian Institutes for Health Research. And just want to also acknowledge my co-researchers involved in this work. And that's it.
Thank you very much for that very interesting presentation. So now we have some time for Q&A. And I have a question for Luisa from Dr. Mystery. So Luisa, what might explain the higher risk of tobacco use in gender fluid versus cisgender individuals?
Great question, Ritesh. So thank you for that. So the answer to that is quite complex. The way that our society conceptualizes gender and gender identity, we tend to think of gender as binary. You're either male or female, man or woman. And so anyone who crosses those culturally defined categories experience a lot of stress and discrimination from people. And often, transgender people, when they do come out and embark on that transition process, often there is this notion that there's an endpoint to that transition process. So if I was born female, assigned at birth, and I transitioned to being a trans man, that, when I complete that transition process, I'm done, right? However, a lot of people, and we were also surprised by this within this data set, a lot of people moved back and forth among those categories. And so we can't think of it like this linear, finite process, but rather sometimes it's an ongoing evolutionary process. And for some people, being gender fluid is their norm, as it were, that it's not just like I'm going to end up being one particular gender identity and then that's it. I also want to mention that in this data set, the way that the path asked the question regarding transgender identity was using a one-step process, which is, do you identify as transgender, yes or no? We know from prior research that that way of asking the question actually limits how people answer that question. And so at the end of the day, it actually could be underrepresenting gender fluid individuals in the population. So I think it's great food for thought that how the question is asked can also impact how people perceive and answer it. But I think the fact that we think of gender as this fixed category that has a finite end to it can create more stress for gender fluid individuals. And so when they come for help, for tobacco cessation or for healthcare, when healthcare providers don't understand the diversity of gender identity, that it can actually create more barriers to receiving care.
So, very, very interesting subject. So you think that the higher prevalence among gender fluid is due to barriers to cessation, or there is also an increase in initiation? Because the difference in how the stress that is put on those individuals.
So we didn't assess initiation. We assessed like how many people are smoking by wave 4, right? And so I think kind of to explain that the fact that gender fluid people live in a culture that defines gender identity as these fixed categories can produce more stress, and and that can then also create barriers when they try to seek care, whether from tobacco cessation specialists or from healthcare providers.
Okay, thank you. So, got a question for Pete. Pete, what would be a reasonable explanation to the disagreement between the direct observations and the model for African Americans, for example, or not Hispanic, Black?
Yeah, that's a good question. I think so. In terms of like what we were able to include in the model, it was a very limited set of covariates, basically sociodemographic measures. But I did include a lot of interactions. So the main one being sort of a three-way interaction between sex, race, and ethnicity. And then we also noticed that once we include a random slope for race and ethnicity, that our our comparisons improved a bit. So part of it could be just not having enough information. The other part could also be even though the ITC had over the 18 years of data that we have, and we've got like 20,000 observations from 12,000 respondents, we still might not have enough enough Black people in each of the different census divisions. So it's just not good enough to estimate. And then there could be also the risk of, we're borrowing too much strength, so we're kind of overfitting a bit, and we're just getting it too smooth, so that maybe the observations from white people are influencing that overall pattern a bit too much, and there's just not enough information in the data. But having said that, I still think it's doing a reasonably good job, and it's clear that it does a better job in some census divisions than others. So if you look at sort of the Hispanic group in the Pacific and the sort of mountain areas and the west, south, central, it does better than in some of the other areas. So, and you might expect that because there's larger Hispanic populations. So the ITC survey would have picked out the larger groups, and then we just have more information to work with. Mm-hmm. Does that answer your question?
Yeah. So, have you already? Do you already have out a publication talking about the implication for policy? Because these are, this has a lot of potential for, informing FDA in the implementation of a menthol ban.
Yeah, no, I agree fully. And I'm working on writing up the results now, trying to figure out where to pitch it and what might be a good avenue. I've had a few suggestions. I think the trick is there's a lot here, and the methods need a good description to understand it, so that's going to lengthen the paper a bit. But so yeah, there's a lot of considerations, but definitely I'm working on writing this up and getting it out so that it can be useful.
Great. So those are very important results. So I have a question for Pete again from Ritesh Mystery. Can SAE or similar methods be used to understand prevalence and trends in a small sample demographic groups? For example, gender fluid individuals? If so, how?
Yeah, so you could actually adapt the method so it doesn't have to be applied to sort of geographic areas. Anytime you've got a small subset in a population, you could use the methods to predict outcomes in those small groups. So it comes down to a small domain, and a small domain is just kind of a group for which a survey wasn't designed, but yet you want to try and get some useful information. So you could adapt it to other small domains, not just necessarily geographic areas.
Sure. Excellent. Well, thank you very much. And so I think those are the questions we have. And these have been great presentations, very, very important results. We thank you for the time.
Dr. Mendez.
I have one more question here for Luisa. How does the minority stress model apply to your research?
Yeah, thank you for that. So I've used the minority stress model as a theoretical framework to guide many of my other studies that I've done, not necessarily using the PATH data, because in the PATH data, it doesn't really ask about minority stress related to transgender identity. So I have used the minority stress model. And what we found is that when we look at sexual minorities as well as gender minorities, that minority stress is associated with tobacco use and tobacco use disorder.
Thank you so much for the answer. And any more questions from anybody? Well, if not, I would thank you again very much for your time and for the excellent presentations. And we look forward to seeing, the consequences of your research that I think are going to be very important. Okay, so have a good afternoon, everyone.
Thank you.
Thank you.